now would like to invite Dr. VAISHALI UNE. She is the head of department from SBH GMC Dhule, and she's going to be speaking to us on MED.
Good morning, eminent people on the dais and off the dais. And just coming in between the myopinized and atropinized topic, a small break, I'll go to the strabismus. I just want to know, I see a few familiar faces. How many of you in the audience as pure strabismologist? So that will depend on the duration of my lecture, how fast I go. So yes, let me begin. I'm going to talk about managing MED, that is monocular elevation deficit. And most of us know that it is characterized by unilateral defect in elevation. Earlier it was known as a Duane's elevator palsy. So it is a misnomer because it is not caused by inferior oblique or superior rectus muscle paresis, but it is MED can also be associated with the jaw winking phenomena. It is present in only 0.5% amongst the strabismic patients and can be either congenital or acquired. 25% of the cases have true ptosis, meaning that there is a elevation, the globe problem also and the lid problem also. There is ptosis associated with it, whereas 75% cases are just of the pseudotosis, that is because of the hypertropia. The lid follows the eyeball. Clinical features: altered head position, that is the chin up, and large hypertropia in primary position. When the eye is fixing with the normal eye, we have pseudotosis and hypertropia in the affected eye, whereas when it is fixed with the peritic eye, the ptosis disappears and hypertropia is seen. Bell's phenomena is also noticed, and there is concurrent strabismus in few patients. So just I want to show a small video on the jaw winking, Marcus gun jaw winking phenomena. Here we see the ptosis, here we see the hypertropia, and when the child is opening and closing the eyes, we can see the movements of the lid. Etiology, I'll fast go through it because most of it is theoretical. It is secondary. There are three various views about elevator muscle paresis. Then second is due to the inferior rectus muscle restriction, and another one is third is about the combination of the both, where all the two mechanisms are involved. In acquired causes, we have CVA due to secondary to hypertension and thromboembolism phenomena. There can be mid-brain tumors, psychosis and syphilis, and also post-traumatic we can have a monoocular elevation deficit. The most important test we have to do is the cover test and the force reduction test. So why I am stressing it on the cover test, because once you cover the normal eye, you will see if there is pseudotosis, the ptotic eye will elevate, and then you won't see the ptosis anymore, and there will you are less likely that you will refer the patient to the oculoplastic surgeon. So it is more of concern to the strabismologist. Force reduction test is, I'll skip this video. So differential diagnosis, we have the various syndromes, inferior oblique palsy, Brown syndrome, superior oblique overaction with the A patterns. Vertical Duane's can occur where there is globe retraction in down gaze. And blowout fracture, you need to be aware, especially students who are doing their residencies. So what is the treatment management? Yes, need is do the surgical correction, and surgery is indicated if the child has amblyopia or significant cosmetic chin eye elevation. We have to rule out whether the child has true ptosis or pseudotosis, which I have already mentioned earlier. So the plan is customized. If there is most important first thing I would like to stress for the, especially if the residents of fellows who are there, that most important is doing the cover test, find out whether it is true ptosis, pseudotosis. Second important test is the FDT. So if the force reduction test is positive, and if you find that there is inferior rectus tightness is there, if you recess it and there is element of true ptosis, then you can do the ptosis correction either LPS resection if it is working well, or the sling surgery. If it is FDT is negative, there is no restriction, you can do the Knapp surgery, the ptosis correction with, and again if the element of true ptosis is there, you can do the LPS and the sling surgery. In jaw winking, which I showed the video, you can do the Knapps and then either go for the crest spectacles or disinsert the LPS and then do the sling surgery. What is a Knapp's procedure? For the uninitiated, we transpose the horizontal recti to the superior recti or vertical recti so that hypotropa element is corrected. I will like to show a augmented Knapp's procedure. I acknowledge Dr. Shubhangi ma'am for giving me this video to show it to you. In short, I will just show that the horizontal recti are identified and sutured, and we disinsert because we are going to transpose the horizontal recti to the vertical recti. So this has been identified and cut, and now this is another medial recti, lateral rectus. Again identified, we have taken the sutures, beautifully done surgery by Dr. Shubhangi Bhave ma'am. And now we will identify the superior recti muscle, we hook it, and then we place the horizontal recti beside the superior recti muscle, we suture it here so that this is done to correct the hypotropia, and also the elevation is helpful. And then why this is augmented? Because here we have to take 8 millimeters away. Yeah, this is 8 millimeters away, and here another suture is taken to reinforce the surgery. So again same for the other recti, it is sutured beautifully, and then this suture is taken to reinforce that. So this becomes an Knapp's, augmented Knapp's. If we don't take these sutures, it will just become, yes, this suture is most important, and yes, a clean surgery. So my talk is on the recent advances. So basically the surgical methods are the Knapp's, modified Knapp's and the augmented Knapp's. And nowadays we have done already the inferior rectus recti during along with the contralateral superior rectus or inferior oblique surgery also are tried. There are various studies. In case of superior oblique overaction, along with the MED, we can do a Knapp's procedure, and it was combined with the superior oblique tenectomy to reduce the overaction, done by Bandyopadhyay et al. And in cases associated with horizontal deviation, the resect procedures along with Knapp's is done. Where the deviation is within 30 prism diopters, only resection is preferred rather than recessions. So take home message is that in all cases of ptosis, examine the eye for evidence of hypotropia. We have to snatch these patients from oculoplastic colleagues. Do the cover test, examine the extraocular muscles in details, and FDT is important for your plan of action for the surgery. Customize each case and plan accordingly. Thank you for patiently listening.
Thank you, Dr. UNE.
Yeah, and continuing with the myopic, sure. One word is, I would like to, the basic thing I would like to tell all our my colleagues is that ask your patients to have more outdoor activities, rest. Everything has been detailed so wonderfully by the team. Each and every aspect has been covered. Congratulations.